Well, good morning, everybody. Thanks for joining us today. I'm Eric Linzer, President and CEO of the New York Health Plan Association. Welcome to today's webinar, Utilizing Virtual Cardiac Rehab to Improve Participation, Cost, and HEDIS Measures. This is one of the many webinars and forums that HPA hosts to keep our members up to date on issues and events affecting our industry. So thank you for taking the time to join us. I'd also like to thank Moving Analytics, an HPA affiliate, for sponsoring today's session. Now, while research shows that patients who complete cardiac rehab live longer and have fewer readmissions, unfortunately, less than 20% of eligible patients participate in these programs nationally. The lack of cardiac rehab participation has received national attention and is now a HEDIS measure, as well as a new addition to Medicare's list of covered telehealth services. And while cardiac rehab has been shown to help patients recover and avoid future cardiovascular events, today's webinar will look at some of the barriers that patients face to getting engaged, including issues related to access, cost, and transportation. Today's session also will include a case study of how CDPHP, an HPA member, has increased access to cardiac rehab and improved member outcomes through a collaboration with the New York State Department of Health and Moving Analytics. Now, with us today, it's my pleasure to introduce Adi Adesanya, who's the co-founder and president of Moving Analytics, a telehealth company that works to increase access to cardiac rehab and helps patients recover faster at home using an innovative app-based virtual cardiac rehab program. Also with us is Dr. Bruce Copeland, who is Vice President of Specialty Transformation and Medical Director at CDPHP. In this role, he promotes and monitors the health plan specialty provider relationships, including value-based payment models and the deployment of appropriate support services. We're also joined by Cherie Murphy, who currently serves as a consultant to the New York State Department of Health on the implementation of the CDC Innovation Grant funding, which is aimed at finding new ways to increase referrals to and participation in cardiac rehabilitation programs in both traditional and home-based settings. And finally, we have Zainab Magdan Ismail, who's the Vice President of Population Health and Hospital to Home at CDPHP, where she oversees the health plan's Hospital to Home program. Now, before I turn it over to Ade, we wanted to let you know that there will be an opportunity for Q&A at the conclusion of today's presentation. This is an interactive session, so if you wish to submit a question, enter it in the chat section that you'll find at the bottom of your screen, and we'll try to get to as many attendee questions as possible. We are recording today's session, and we will be making copies of the presentation available following the webinar. With that, thank you all again for joining us, and I'll now turn the session over to Ade. Good morning, Ade.
Morning, Eric. Thank you so much for that great introduction of the webinar today and also of the attendees. We're really excited and grateful to the Health Plan Association for allowing us to host this webinar and talk about this very important topic. So the format for today's webinar is really going to be a dialogue between myself, Dr. Copeland, Cherie, and Zainab. And we're going to talk about an innovative collaboration that the Department of Health, CDPHP, and Moving Analytics has formed to really address the issue of cardiac rehab in the region of Albany, New York. So for us to get started today, would like to get a better sense for the audience. So we're going to do some poll questions just to get a sense for, who's in the room and how familiar you are with the topic. So Arlene, if you can help me pull up the first poll question in terms of, how familiar are you with the topic of cardiac rehab and its importance to your members? All right, so let's see the outcomes. All right, so it's a pretty interesting mix. So 44% of people are very familiar and 56% not familiar. So hopefully we can educate, the audience today about just the importance of cardiac rehab. So let's go to the second poll question. And for those who are familiar with cardiac rehab, what percentage of your membership today participate in cardiac rehab? And there's also an option for if you don't know. So, so let's run that poll question. Arlene, I didn't see the question on my end. Is it showing up for everyone for the second question? Great, thank you. All right, let's close that poll question and let's see the outcomes. All right, so most people don't know. Some people feel like 30 to 60% participate. That's actually pretty good. And then a lot of people feel 0 to 10%. All right, so that's good. And then the final question is just, what's your role in your organization so that we have a sense for, where you sit in the value chain. All right, so let's close out that poll. All right, so lots of clinical people and innovation and quality improvement. Awesome, so this is a good audience. All right, so thank you, Arlene, so much for those poll questions. So to get started, Bruce, you've been a cardiologist in New York for decades, and you also have a very unique role at the health plan as well. So, from your perspective, what are the benefits of cardiac rehab from a cardiologist perspective, but also from a health plan's perspective?
From a health plan's perspective, I mean, cardiac rehab is really well established that it decreases mortality, decreases readmissions, and decreases future cardiac events, which is why it's a mystery to me that adoption has been so much of a challenge. It's a class 1A recommendation from AHA, ACC, 13 to 24% reduction in total mortality over 1 to 3 years, 31% decrease in rehospitalizations over a year, and basically improving quality of life. And it's always surprising to me because everybody always wants to sell this to the doctor or to the hospital. And it's generally a money-losing proposition for a physician's office. We tried it for years, and it was hard to make a go of it. The other group in town had a similar experience, and the hospitals at best usually break even. And you really want to look at who really saves the money here, and it's really the insurance company. We can decrease readmissions, and every readmission is very costly. And so, for us, for our members, to keep them out of the hospital, to decrease their mortality, to improve their quality of life, and we save money, it's kind of a no-brainer, from a health plan point of view.
No, definitely. I totally agree with that. The value of cardiac rehab, I feel the biggest beneficiary is the member itself, but after the member is the health plan. So what's your perspective on what percentage of eligible members, who qualify for cardiac rehab actually participate in the state of New York?
This is kind of a depressing slide. If you look at which states are consistently ranked the most unhealthy based on obesity, smoking, MI rates, stroke rates, it's usually Alabama, Arkansas, Mississippi, kind of the Louisiana, kind of the Gulf Coast states. We're being outperformed by them. The only state doing worse than we are is Hawaii. And our enrollment rate in New York State and locally is about 16%. And this is a low bar. This is enrolling for just one and showing up for just one session. And this data is based on the percent of hospitalized cardiac rehab eligible Medicare beneficiaries in 2017 who completed one session within 1 year of their qualifying event. So this shows nothing but opportunity, but it's depressing with all the data out there that we are performing so poorly. And interestingly, the Midwest and the Rocky Mountain states tend to do a lot better. And we really have to be committed to doing a better job here. This is just not an acceptable statistic.
Yeah, totally agree. So from your perspective, right, what are the barriers that members face and, in attending cardiac rehab today?
There's several. One is, high copays. If you're going twice a week and it's $30 a session for a lot of people, that's prohibitive. And as we'll talk about later, we've waived copays for cardiac rehab. If you live far away, the distance involved can be a challenge in terms of transportation. So if you had a bypass operation or a valve surgery and you can't drive for 6 to 8 weeks, who's going to be bringing you? And even if you can drive, in the winter weather, it's a challenge. I think one of the biggest limitations of brick and mortar is the inconvenient schedule. You're really stuck on a brick and mortar schedule, which is going to be 8 to 5, 9 to 5. And if you're back to work or anticipate going back to work, that's very hard to fit into your schedule. And most patients, if they do brick and mortar, they'll do it for a short period of time. They feel better and they just give up because they want to get back to work and they don't want to have this inconvenient schedule. Physician referral is my biggest frustration. You think cardiologists would be part of the solution, and I think cardiologists are actually part of the problem. They don't acknowledge the importance. And they don't sell it to the patient. If you buy in as the cardiologist and you convey that to the patient, they're going to do it. But what happens is patients will come in 6 to 8 weeks after that, an angioplasty or a non-ST elevation MI, and the doctor say, "How you doing?" "Well, I'm walking a mile a day." "Oh, you're doing great. You don't need rehab. You're walking a mile a day." They're missing out on the whole benefit of rehab. It's not just the exercise; it's a lifestyle change. In Albany, one of our big obstacles, and I think it's probably true elsewhere in the state, are limited brick and mortar locations. We had one in Albany, one in Troy, and during COVID, we had no cardiac rehab. They both shut down. And in Albany, I don't know what it is, but you would think you were asking the patients to swim across the Hudson River to go from Albany to Troy or Troy to Albany. It just won't happen. And the medical center, which is our largest, academic institution, does not have cardiac rehab. So they would use the St. Peter's facilities, and they did not have adequate spaces for everybody involved, resulting in long wait lists. And it's not uncommon for people to not be able to start rehab until 2.5 to 3 months after their qualifying event. And lastly is the missed days of work. And again, that's part of the inconvenient schedules we were talking about above, but people can't leave work 2 days a week for months. And that's a serious limitation, again, to brick and mortar. So brick and mortar, they have some of the most dedicated people, I've seen. They're big advocates for cardiac rehab, but there's certain inherent limitations to brick and mortar that you just can't get around.
That's very helpful, Dr. Copeland. So let's talk about what CDPHP is doing, and from your perspective, to increase cardiac rehab participation.
We've decided to waive copays for cardiac rehab. And again, that's somewhat dependent on line of business. Our ASO clients, that's up to them. We're going to try to educate each of our ASO clients to encourage them to waive copays. But otherwise, for Medicare, Medicaid, commercial, those are being waived. Physician education and incentives. Physician education is actually more important than I think people realize. That people assume cardiologists actually know the data showing the benefits of cardiac rehab, and I would argue that actually most don't. And if they see the data, and if we can really educate them, I think they'll be better advocates. On our end, we've tried to increase that education through various talks, handouts, and also some other physician education programs that we're running through our specialty value-based payment model. But we're also incentivizing the physicians. And not incentivizing them to enroll the patient, but incentivizing them to teach the patient about the benefits of cardiac rehab and then subsequently enroll them. So they get paid at the time of enrollment, but we go back and check the chart to be sure that it documents that they've in fact spent that time educating the patient on the benefits of cardiac rehab. And then I think the biggest thing that we've offered is the implementation of virtual cardiac rehab, which is why we're here today. But we feel very strongly about virtual care in general. We're trying to offer a virtual option in pretty much every area that we're involved in. And we've rolled out virtual programs in behavioral health as well, which has been a huge asset. And we're currently working on PT and some other virtual options. But in addition to the standard virtual options you would have with your primary care doctor or specialist. But we're a big believer in virtual cardiac rehab because it gets around so many of the obstacles. And it's not for everybody. And we're not telling people that we want them to do virtual. We give them the option. We just want them doing cardiac rehab. And we'll even allow a switch. So we'll allow one switch. So if you start out with brick and mortar and you realize it's just not consistent with your lifestyle and you want to change to virtual, fine. If you start out in virtual and you feel insecure and you really want somebody face-to-face, you can make that switch. But we want to present the option, and we really want people to complete it. It's not enough to just start it. And I think that's, again, the big limitation of brick and mortar. Right after an event, they'll start it, but the likelihood they're going to complete it is virtually zero. When you look at the completion rate as well as the enrollment rate with virtual compared to brick and mortar, it's really an astounding difference.
Yeah, I'm curious, Dr. Copeland, what's been one of the surprising things you've encountered, from that physician education perspective, like you said, even cardiologists don't always know all the benefits of cardiac rehab. And sometimes they think of it as just like an exercise program. From just this initiative, I'm curious of what's been surprising to you in the work you've done educating cardiologists about this.
How few of them really push it, and the data is overwhelming. It's not like just one study, and it's a big enough issue that it is being made a HEDIS measure. And I'm very surprised at how many physicians actually don't know the data. Cardiologists, not physicians, cardiologists. This is data that should be right on the tip of their tongue. And I have to be honest, I practiced for 32 years. I've been in this role for 2.5. There was parts of the data that I didn't know. I pushed it. I was one of the biggest referrers to cardiac rehab. But I have to be honest, when it came down to the real specifics of the data, as far as mortality and decreasing future cardiac events, as well as such a profound decrease in readmissions in the first year, I can't say that I could have, spoken on that and with any kind of competency. So yeah. I think there really is an opportunity here to educate the doctors.
No, I totally agree. And I think that, that's something that I feel like CDPHP has done very well, is educating those providers on the benefit so that they can become advocates to patients. And we find that, when the cardiologist really spends the time to talk to the patients about the importance of cardiac rehab, there's a very, very high chance that the patients are going to enroll and also complete the program. So let's switch gears and bring up Sherry to the virtual podium. Sherry, you've been working with a lot of the local cardiac rehab programs, the health systems, and the cardiology practices. So from your perspective, what are some of the limitations of the existing cardiac rehab programs in really delivering cardiac rehab to more members?
Well, I think actually Dr. Copeland did an excellent job of introducing this topic. And I don't think any of these limitations to sort of the traditional or center-based cardiac rehab are new. But I think what is new is how COVID exacerbated many of these issues, such as space and staff limitations, given the safety restrictions that folks have to have in place. And then, as Dr. Copeland mentioned, that acute availability of, or the acute lack of availability of the center-based rehab during the height of the pandemic. And while that may have been temporary, I think we're just more mindful of the possibility that something like that could happen again. I guess you'd call it sort of preparedness, right? And what would be the plan to have in place should something like that happen again. The other thing that I think is relatively new is maybe the technology, or maybe the widespread use or acceptance of the technology. And I think Dr. Copeland really touched on this too with the other CDPHP initiatives that they have going on. While we've known about these limitations for a center-based or traditional program for years, because they're not new, and the idea of telemedicine also isn't a novel concept. Perhaps another one of these, COVID silver linings. I find these in my life where something has happened as a result of COVID that is actually an improvement in lifestyle. I think one of the COVID silver linings we all, find in different areas has been sort of that, I'm going to call it maybe a cultural shift, or just the expedited diffusion of innovation, or more widespread acceptance of alternative delivery models, like Dr. Copeland mentioned, just providing care in a virtual way, almost out of necessity. So I think we have a lot of opportunity now to be able to think beyond our traditional implementation of cardiac rehab and overcome many of these limitations. Like Dr. Copeland said, not pushing aside the traditional programs that we have, but being able to offer another equivalent option to meet patients' needs and just expand access.
No, definitely agree. And I think one of the things that's interesting about telehealth is obviously COVID brought it to the forefront of things. But I think in the areas of cardiac rehab in particular, there's always been an access issue for cardiac rehab. And I think what COVID did was really show that telehealth was a viable option, right? And telehealth, going forward is probably as important as the brick and mortar for those two models to coexist so that patients have just choices. Because of, again, if we have only 15% of patients being able to access the service, this is really not just a COVID issue. This is a fundamental access problem, and hopefully telehealth can solve that. So let's talk a little bit about, what's the Department of Health doing in New York to increase cardiac rehab participation?
Sure. So the department's interest or efforts around increasing cardiac rehab participation really stem from this 5-year CDC grant that, as was mentioned earlier, is really aimed at reducing risks, complications, and barriers to preventing and controlling cardiovascular disease. So there are other initiatives happening under the umbrella of this grant. But one key strategy is to increase cardiac rehab participation and then ultimately completing more sessions. Obviously, since the State Department does not deliver care, the approach of many of the efforts from the state include working and supporting our community partners who do provide care or services. This particular project working specifically in the capital region and working with those community partners who are involved in the process of getting patients referred to rehab to really break down those barriers to participation and implement strategies to improve the referral, participation, and completion process. You can move to the next slide.
Okay.
As this is a 5-year effort, we've really followed sort of a stepwise and layered approach. And we have a great resource out there to follow, which is the CDC's Cardiac Rehab Change Package. Really provides a roadmap to change concepts and ideas and tools and resources to make improvements in participation, referral, enrollment, and completion of cardiac rehab. So if you move to the next slide, the first focus area we had was making cardiac rehab a system priority and the referral process. And we started by engaging our acute care hospital partners as really a low-hanging fruit in this, given that they're the, I would say, key referral entry point for eligible patients. You've had a procedure, you're hospitalized. This is usually a good, the key entry point for patients. They also had structure and data systems in place to measure their referrals. So it really was a good place to start. And so the key interventions that we worked toward implementing in these first 2 years were regularly reviewing the performance in referring eligible patients to cardiac rehab and making sure that the people involved in that process saw that data. A lot of times, people collect data, but it doesn't really go beyond the collection point. So really making sure that they were using this data and sharing it. And then also using their EHR or EMR tools to automate the referrals, making sure that patients were educated, ideally using this idea of a cardiac rehab liaison, which we can get into later. And most importantly, I think, the healthcare system can be traditionally siloed. And so while a great referral process may exist for, say, your CABG patients, they may not similarly exist for all of the PCI intervention patients. So we really wanted to make sure where hospitals may have had a best practice referral process, for a certain subset of eligible patients, that was really expanded to all eligible patients. You can move to the next slide. Just looking at a sample of hospital registry data, we did see that these efforts were successful in increasing the referral of eligible patients to cardiac rehab. So we know, though, however, you can go ahead to the next slide, that referral doesn't necessarily translate into participation. It's a necessary first step, right? You have to be referred in order to participate. And over the course of those first 2 years working with the hospitals, we heard a lot of pushback from them that there was some ownership from other stakeholders in the healthcare system that were barriers to them getting patients to participate. Things Bruce already said, copays are too high. They live too far away to come to a traditional brick and mortar site. They don't drive when the weather's bad, COVID restrictions. So our next step was really to look at what we can do to improve, I call it the conversion rate of referral to participation. And so this is a much bigger challenge, I think, than the referral issue, because there are just so many factors associated with a patient's likelihood of participating in cardiac rehab. And while many of the obstacles and barriers to participation can't be changed, like you can't necessarily change a patient's characteristics, it just makes it more imperative that we focus on the modifiable barriers. For instance, what can we as a health system do to modify this access to care barrier, like the insurance coverage, the long distance, lack of transportation? Another key modifiable factor, which studies have shown being the most important influencer of participation, is that strength of the physician referral. Sometimes, even though that automatic referral is really the ideal process, you know, it's an automatic referral to cardiac rehab, the mechanism, like the mechanics of the referral, are seamless, right? And we're checking that box. Yep, we made that referral. We pat ourselves on the back. We did a good job. But sometimes it can be too automated. And then we lose, like Bruce or Dr. Copeland was saying, that strong encouragement from the physician provider, which ultimately is going to be what gets the patient into cardiac rehab. We hear all the time, you know, that referral's been made because we checked the box in the EMR. Cardiac rehab calls the patient and they'll say something like, I need to talk to my physician. You know, they really do rely on the recommendation of their physician provider to guide and direct their care. So, so taking all of those things into consideration, moving into years 3 and 4, we continue that partnership with the hospitals and progress that work with hospital-based rehab programs for them to establish a data-driven approach to looking at program performance, identify metrics to drive improvement in their enrollment and participation. The rehab programs were not traditionally looking at performance measures for enrollment, as their certification requirements were really looking more at outcomes. So this wasn't really something they were looking at. It was more, you know, general ideas of what their participation rates were like. So this is sort of a new process for them. And actually a recent change to the AACVPR certification requirements puts this initiation measure into their repertoire. So this sort of data-driven approach will help identify their areas for improvement and work on implementation strategies to make those improvements. But also in year 3, we started to work with CDPHP to address some of the payer impacted barriers, understanding that this is really a systems issue, and that we can't just work with the hospitals and the rehab programs alone in order to address all of these barriers to participation. So we were able to engage them to address some of these access to care and cost issues.
Thank you, Sherry. And I think just engaging all the stakeholders. I think that's the right approach, because it's not just on the provider side. There's a lot of things they can do, but there's a lot of limitations on things they can't do. For example, in copays, in terms of waiving copays, which we know is a big barrier to access, and also in providing virtual cardiac rehab or telehealth-driven cardiac rehab as an approach. That is something that the providers can implement, but they still need reimbursement from the health plan. So I think that just the approach of working with both the payers and providers, that's that's been very effective. So switching over to Zainab. So Zainab, from CDPHP's perspective and from your role in population health, what motivated you to address this cardiac rehab problem? I spend a lot of time talking to many health plan leaders, and many of them acknowledge that they have a cardiac rehab problem, but not all of them do something about it. So kind of what made you guys do something about cardiac rehab?
Sure. So I think you heard from Bruce. He's a cardiologist. Obviously, he's very passionate about this. We've read all the literature that says, as Sherry mentioned, copays are a huge problem. Transportation is a huge problem. So, kudos to Bruce and our leadership who said, let's just wave the magic wand and eliminate copays, add a virtual option, really, put a big focus on working with our physicians. My job at the health plan is really on the implementation side. So I'm population health. And anytime I'm asked to work on a problem or look at a problem, my first question is, well, how much of a problem is it? So I thought it was very interesting when you asked the poll question, what percentage of our members go to cardiac rehab? And I wrote it down. I think most of us on this call didn't actually know. So when we looked at our data, we found that about a third of our hospital admissions are cardiac related of some sort, heart failure, MI, that type of thing. But when we actually looked at what percentage of our members were actually going to cardiac rehab, it was a mere 16%. Then we were able to drill down a little bit further because obviously we get claims data. 15% of those members actually completed all of their sessions, of which there are 36. So 2.5% of our eligible members were actually going to cardiac rehab. And in my mind, data is a huge motivator, and room for improvement is the second huge motivator. So, yep. Yes, we wanted to do all of these things. And I think as health plans, we need to really think cautiously of, if we make a case for doing something, we need to show a return. And so the challenge for us was, okay, we've removed these barriers, and now how do we actually make it happen? And that was, sort of where I fit into this puzzle. The interesting thing, you can move to the next slide too, as many have mentioned, is cardiac rehab, as a flashlight has been shone on this issue, is a HEDIS measure, and that was brought to light last year. There are several pieces that you see on the screen here: initiation, engagement, achievement. As we've been working with our physician population or physician providers, we've really focused on the importance of educating the member. And then we're really as well incentivizing our docs to work on initiation. So the first measure here, which is getting people into cardiac rehab early. So 2 sessions within 30 days. And then also making sure, as Bruce mentioned, we see people engage in cardiac rehab. That was the 16% that I showed, but not that many people complete it. So we're also really focused on, okay, it's great that you educated and you got folks in. How do we ensure that folks actually complete cardiac rehab?
Oh, thank you, Zainab. And I think you hit the nail on the head. I feel like if you don't look at your numbers and your data, it's really hard to make the case for improving this. And one of the things we find is that once a health plan actually does the work of just looking at the data in terms of cardiac rehab, how many members are eligible, what percentage of them do cardiac rehab. I think what's even more interesting is when you look at the data around, even the small percentage of members who do cardiac rehab, when we look at their outcomes from a cost and readmission perspective, and we compare it to the rest of the population that don't, you find like very, very stark differences in terms of fewer readmissions and better outcomes in that population that do cardiac rehab. And I think that that's kind of one of the keys to making sure that, you can then create a business case around, hey, if we increase cardiac rehab access, through the different, things that Dr. Copeland mentioned earlier, including copay waivers and implementing virtual cardiac rehab and engaging the physician community, then there's a huge return back to the plan. So I think that it's wonderful that you've been able to just take the time to look at the data to make that case. So let's talk about, Zainab, from the implementation perspective, how does virtual cardiac rehab, or even more broadly, how does cardiac rehab work from CDPHP's perspective?
Sure. So I think this addresses, again, a fundamental question that we struggled with in the beginning, which was, or we realized that folks just weren't talking about cardiac rehab. And so in order to even bring up the concept of virtual rehab, we first had to start with educating everybody about rehab. So like Rehab 101, what's the importance of cardiac rehab, including our rates. So again, I said, data is motivating. As we went to our hospitals, we showed them, this is your rate of patients that are going to cardiac rehab. In general, the number of patients who were going to cardiac rehab from several of our hospitals for heart failure was around 2%, even being referred. So it's just very interesting. So we did sort of this roadshow of educating everyone about cardiac rehab, hospitals, providers, even our patients. And then from a CDPHP perspective, we are fortunate that we have embedded care managers at some of our large hospitals and our large cardiology practices. So they are able to help us identify who's eligible for virtual cardiac rehab, and then educate as well, in general, the options between, what are the pros and cons of home-based cardiac rehab, brick and mortar, as well as virtual. But one of the important pieces that we realized along this journey, and we've been at this for about a year, so we started actually April 1st of 2021. We were planning this pre-pandemic, and then as Cherie said, the pandemic hit, and it was sort of like fortuitous timing for us. But one of the important pieces is explaining what virtual rehab is. And here's where I'm gonna take a bit of a turn, Adi, and turn the tables on you and ask you to explain, because I think you're best at doing it, how Move-In actually works. And that's one of the things we've been spending a lot of time on here at CDPHP.
For sure. Feels good to be on the hot seat. But so let's talk about how virtual cardiac rehab works and, and our approach at Moving Analytics. So, like everyone has mentioned today, cardiac rehab has a fundamental problem of access. And so how we're solving that access problem is really to use technology to help patients be able to, do cardiac rehab. So every patient in our program gets an app on their phone or tablet, and we support both the iPhone and the Android. The patients also get a remote monitoring care kit that includes a smartwatch that has a heart rate monitor, like an Apple Watch. Patients get a blood pressure cuff, a scale, and some educational booklets and some activity bands. In addition, every patient is paired with a dedicated cardiac rehab coach. And that cardiac rehab coach is the one that works with the patient over the course of a year on some of these clinical areas that you can see on the screen, like, helping them improve their cardiovascular fitness, helping them adopt a better diet, helping them with, strategies to reduce their stress and anxiety, quit smoking and medication adherence. And medication adherence is a very, very important component to cardiovascular recovery, especially when we think about how we manage hypertension and lipids. So that's kind of at a high level, some of the goals of the Moving program. One of the things that was very important to us when we started the company and decided to build the program was to make sure that our approach was based on very strong clinical evidence. So we found that at Stanford, they had done a lot of research in home-based cardiac rehab, and they had published, they had done about 6 clinical trials and published really good outcomes. So we reached out to Stanford and we actually partnered with Stanford to develop this clinical model for delivering cardiac rehab at home. So we took their model and we've essentially digitized it. So in terms of cardiac rehab and some of the components, exercise is a very big part of cardiac rehab. So, in our program, the member or the patient is exercising 3 to 5 times a week at home in the program. They are using the app to follow along to do their cardiac rehab exercises. They also use their smartwatch to track their intensity so that, they are staying within the safe ranges of, the heart rate while they exercise. So that's a pretty big part of the program. Patients also get coaching. So from their coach, patients get up to 14 one-on-one coaching sessions over the course of the first 12 weeks. And during those sessions, this is where the coach is working with the patient to address those clinical areas that we talked about in the previous slide around exercise, nutrition, stress. After the patients complete the first 12 weeks, then we move them to what we call a maintenance program for 9 months. And the idea there is that patients continue to use the tools that we've given them to do their cardiac rehab. One of the things that I'm proud of in terms of how we've been able to structure the program, both with CDPHP, is that patients get to keep the app, the devices for life. So, this is not just like a 12-week program where you give patients some tools and you collect it back. The message we're sending to the patients is that, we want you to really change your lifestyle and have a heart healthy lifestyle for the rest of your life. So you get to keep the devices. From a technology perspective, if patients don't have a smartphone or tablet, we'll actually provide them one. And again, they get to keep that tablet or smartphone for life as well. So I think those are some of the innovative things we're doing. So, through the technology, patients are doing the coaching sessions with the coach. The coaches are really helping those patients with any kind of motivational interviewing strategies to help them to kind of adopt those lifestyle changes. And remote monitoring is also a big part of the program. So through the technology, those coaches are getting data back on how the patients are doing, and they're using that to engage the members. And in some cases, they're using that to catch, signs and symptoms that can eventually become an adverse event, and they're coordinating care with the providers to make sure that patients don't have to go into the ER, and they can address those issues more quickly. So that's kind of, in a summary, how the program works. So when we think about some of the outcomes we've been able to show with CDPHP, we're showing that 70% of patients referred by CDPHP to the moving care team enroll in the program. This is a very, very huge number. 83% of those patients, complete the first 12 weeks. And on average, those patients who are enrolled in the program are exercising 32 times within the first 12 weeks. And this is just, very outstanding outcomes when you compare, this compared to what we're seeing in the traditional rehab, which only 15% of patients are completing. The engagement is much higher in a virtual solution. When we think of, the impact of the program on hypertension, for example, we're showing that, at baseline, 71% of members, had their blood pressure under control. At 12 weeks, we've been able to get 82% of those members to improve their blood pressure, which is very significant as well. In terms of depression, I think one of the things that, we like to, and, the CDPHP team has been very good at, is to engage the provider community about, cardiac rehab is a very comprehensive secondary prevention program. So it's not just exercise. And in this slide, you can see that the program is also helping with depression and anxiety, reducing the rate of those two factors in their population as well. And, I think the last slide here before I turn it back to the panelists is, there's usually kind of a sense of who can do virtual cardiac rehab, who uses telehealth. From this slide, you can see that across all age groups, in the 40s, 50s, 60s, 70s, even to the 90s, patients are actually enrolling in the program. And so we're seeing that most of the patients in the program, 32% of them are between the ages of 60 to 69. But, the age right now is really not a barrier in terms of adopting technology. And I think that's something that we're actually very proud to show as well. And so, Zainab, I guess, from a satisfaction perspective, I know you guys recently also polled some of your members. So I was curious if you wanted to share more about, just what you're seeing, in terms of, how satisfied patients are with the program.
Sure. So we were very curious to know a number of things, such as, is the copay a barrier? If it's not, it's not. Is that really why you're going to rehab? We wanted to know whether folks were happy about brick and mortar versus virtual. And one of the questions that we ask consistently, and these were conducted by CDPHP, is how likely is it that you would recommend this program to a friend or colleague? This is similar to the Net Promoter Score questions. And 97% of our members ranked at 7 to 10, 7 or higher. So extremely likely that they would recommend move into a friend or a colleague. And it's interesting to note that most of the scores were in that 9 to 10 category. So folks are really happy. And one of the interesting things from just speaking, these were all conducted over the phone, is that many members say that establishing that exercise pattern at home is something that they're pleased with. And the fact that Move-In monitors their exercise because it's on a smartwatch they actually know, your coach knows whether you're doing something or not, has been interesting feedback.
Thank you, Zainab. So, just, to start to wrap up the webinar, in final thoughts, what recommendations, and this is to the whole group, would you share with other health plan leaders on the call today in terms of, how they can increase cardiac rehab participation in their membership and overall in the state of New York? And Copeland, we can start with you.
Yep. I just want to make one quick point or two quick points. We talked about enrollment, and Zainab briefly touched on completion, but completion rate is really critical here. If you look at the benefits of cardiac rehab, it's actually linearly related to the number of sessions completed. So when patients go to a typical, brick and mortar and they're getting frustrated and they want to get back to work, and they'll say, well, you did 10 sessions, that's great. It's not great. You really have to complete it. And again, I think that's one of the big benefits of virtual, is that there's a really high completion rate. The other thing I want to bring to the table is starting to think of patients as customers, as consumers. I grew up in retail. There is nothing patient-centered about healthcare. So I hate even hearing that concept. This is patient-centered. Virtual is patient-centered. We're responding to a need and a demand from the consumer. So I think we need to think of it differently. One of the key things that, again, I was not aware of previously is the importance of early enrollment. The farther out you get from the qualifying event, the less likely it'll be that you will actually do cardiac rehab. So locally, if you had an MI or you had surgery, you would be told to discharge. We're not even going to talk about rehab. You can talk to your cardiologist about that when you follow up. Well, the follow-up is often 6 to 8 weeks out. Too late, you already missed the boat. And that's, again, not acceptable. So we have care managers in the hospital, and we're trying to enroll as many people as we can in the hospital, or prior to discharge or shortly after discharge. And I think that's really important. We talked about physician buy-in. I don't think we need to go into that again. I think having physician champions at hospitals and practices is critical. One of the ways to get that is to have these patients co-managed. Movin has a chief medical officer at Mayo, who's outstanding and one of the top leaders in cardiac rehab in the country. But getting some local physicians to co-manage those patients and set the guidelines and everything for each individual patient, I think is a great way to, again, engage local physician champions and to get their groups involved. We also find that as we show the data, not only to the groups and the physicians, but to the administrators, they're all over this now. I mean, they realize that they're missing out on a lot of opportunities here, both in terms of our value-based payment model for the cardiologists, but also on opportunities for their patients. The need to include the surgeons. Surgeons were a real surprise. Surgeons are absolutely, they love it. A couple of them wanted to sign the patient up before they even get on the OR table. They want to include it in all their pre-op literature. And tell patients to expect to do this, and we expect you to do this. And again, that was another huge problem. People would have heart surgery, and again, they'd be told, you'll see your cardiologist, and first you'd see the surgeon in 4 weeks, then you'd see the cardiologist in 8 weeks. So by the time anybody even discussed rehab, it was already kind of a done deal. I'll also just jump down to point 9, then I'll turn it back to Zainab. It's very different doing this in an integrated system and a non-integrated system. We are non-integrated, and it's more of a challenge because everybody's not necessarily on the same page. Their incentives are not necessarily aligned, and it's more work. If you're in an integrated system, I think this is even easier to initiate because, again, everybody's on the same page.
I'm happy to take the baton from you, Bruce. So coordinating with cath labs, as Bruce mentioned, trying to get to all the places where a patient may be referred or is a good entry point for cardiac rehab is something we've worked on. But one of the things that I found particularly interesting is if you ask a practice or you ask a hospital, how are you doing on rehab? They're like, we're great. We send everyone to rehab. Well, oftentimes folks were thinking about the MIs, the people who come in with a STEMI, it's obvious that they need cardiac rehab. Those are the people that are oftentimes getting referred to cardiac rehab. So we took a look and dissected the population. There are the planned interventions. So the folks that Bruce is talking about, the surgeons, we need to talk to them about cardiac rehab. Those who are in the hospital, and then those who are also sort of fall into that chronic condition bucket. So like our heart failure patients. And when you're speaking with providers in hospitals, just breaking that out into these 3 segmented populations and saying, what's your process for each of these is an insightful exercise, which I highly recommend. And then I'll jump to point 8 here, which is being flexible. So every hospital, every practice is really different, and being patient from a health plan perspective. We've had to learn to be extremely patient because everyone has a different process, and we're really there to help encourage and improve performance overall. Sheree, I'm going to let you take the EMR in the last point.
Thanks. In the interest of time, I think we've already covered that the use of EMRs is really important to execute the mechanics of the referral and make that efficient, but really that physician recommendation, needs to be partnered up with that. But what I really think is our biggest lesson learned from the public health perspective is that this is really a team sport, and it really needs all stakeholders in the healthcare system engaged. As we shared, we started with the hospitals to increase the referrals because that was the low-hanging fruit. But patients referred don't equal patients who enroll, and patients enrolled doesn't equal patients who complete, which, as Dr. Copeland says, is going to get us to our ultimate goal of best outcomes. So in thinking about breaking down those barriers to participation or those predictors of participation, these can't be addressed by one stakeholder group. Cost and coverage of rehab services is the payer or health plan piece. Strength of the physician referral is really the individual provider buy-in piece. Early enrollment, that falls to the programs themselves to have a process that gets those patients in soon after their event. And having data that is reliable and accessible and patient-centric, not just looking at like how one health plan does or how one hospital does or how one provider network does, but looking at the system as a whole and really making this a patient-centric approach are really key to being able to drive these improvements. So that is our biggest learning, is that the responsibility for improving participation in cardiac rehab sits with all of the stakeholders, and we need to make sure that all of those stakeholders are engaged in this effort.
I'll add one thing to that, Sheree, which is that I think that the provider doesn't necessarily see the patient as a CDPHP versus a Blue Shield patient. And one of the greatest lessons, I think, from this is that we need other help. Our success here at CDPHP and as a community is really predicated on everyone having the option, regardless of what health plan you're on, to participate in rehab.
And I just want to emphasize too, physicians as a whole, providers are like on the edge of a cliff right now. They have no more bandwidth. So processes have to be in place that do not significantly affect their office process and the way they see patients. There's just no more time. And as you address these issues, always keep that in mind. The first thing you have to do in the office is what is their process, and it's going to be different in every office, but it can't negatively impact physician time.
No, thank you all for those really thoughtful recommendations. And, I hope the audience, really has learned a lot today about just how to, the importance of cardiac rehab, what are some of the systemic things you can do to increase awareness, referral, and participation, and how virtual cardiac rehab can also be a tool to help increase access and completion to cardiac rehab. So there's some helpful resources here, and they will be in the recording and the slides, that goes out after the webinar. But we wanted to spend the rest of the time just kind of open this forum up to Q&A in case anyone in the audience had questions for the current team here, so that they can get those answered.
Thanks, Ade. Well, I don't see any questions in the chat function. We do have a couple of minutes before we hit noon. If you do have a question, either put it in the Q&A or chat. In the meantime, I'm going to pose a question to the group, thinking back about that chart earlier in the presentation where New York ranked compared to other states as far as getting folks engaged in cardiac rehab programs. Could each of you maybe give us just one or two thoughts as to, either, A, what others, what's going on in other states that New York may want to emulate, or B, sort of picking up on Zainab's and Sherry's point about community engagement. What would be one thing you'd like to see the marketplace do to get those numbers from, where they are around, 16% enrollment, higher up to what you're seeing in, Iowa or Nebraska of over 50%.
I wish I had a good answer to that. Some of it is just demographics, I think. I have a younger daughter that lives in Colorado, and the first time I visited her, I felt like, if you came to the state border and didn't have a bicycle rack on your car, they'd make you turn around. It's just a phenomenally engaged population. I think we have more variability, but there's really no excuse for this. This is really community awareness and physician awareness. And just saying we're not going to accept this. And just so people know, the best state in the country is still at 50%. If the Million Hearts Initiative, we want to shoot for a goal of 70%, and we'd like to shoot for a goal of 70% completion, not 2% completion. And again, I think there really are some inherent limitations of the system. But even with that, I'm a huge believer in both patient education and physician education. And I think at the end of the day, unless we make it a priority in our local communities, and I think some of that does fall on the health plans, mailings, teaching sessions, videos, all kinds of stuff. I think the health plans have to take a more active role in this because it's saving lives.
Thoughts from others before we wrap it up? Zainab?
Oh, I was going to say, as to how other states are doing, one of my hypotheses is that many states have integrated systems, and it's a little bit easier to refer people to rehab than us here in New York State. That's one of the challenges we found. And my wish list is, or my dream would be, for all health plans to offer the same coverage, no co-pays, virtual rehab, everything. I think we'll do better that way. Sherry.
All right, well,
Are you looking for a closing comment from me there, Zainab? I feel like I've done my wrap up comment there. So we're at the top of the hour, so I don't want to take any more time.
Well, with that, let me thank everybody, again, Zainab, Dr. Copeland, Ade, Sherry, thank you all for taking the time, and thank you to our audience for joining us today. We hope you found this thoughtful, informative, and thought-provoking. As I mentioned at the outset of today's webinar, we will be sending around both the slides and a link to the recording. With that, thank you again for joining us, and with both Easter and Passover upon us, for those of you who do celebrate those holidays, hope you have a great holiday season, and in the meantime, hope everybody has a great rest of their week. So thanks for joining us.
Thank you, Eric. Thank you, everyone.